This is a patient with history of adrenal lesion. Here it is. And on non-contrast, it measured like almost 50 Hounsfield unit, 54.
So it's supposedly, I think above 40 on non-con, you should be really concerned that it's definitely not an adenoma.
Yes. So here are some MR imaging features. Oh, sorry. So that we got an MR. So this is the T2 on MR. There's no intralesional fat. And I will
And it's
show
pretty
you.
T2 bright.
It is T2 bright, actually. Look at that. The urine analysis was negative for pheo. Where I'm looking for my in and a post phase. It- but there was no intralesional fat for what it's worth. Okay, here's a post phase and here's the all right. Okay, so the lesion is right there. Oh my gosh. Ugh. All right, and then there is the post phase. Let me just zoom in so we can see, so it can be convincing.
Yeah, so all those little dark areas are dark on both.
On dark, yep, exactly. They're dark on both. So there's no definite intralesional fat. And the washout was pretty high. It was like 50 or 60%, very high. So I put it into this, there's a adrenal washout calculator from Phil at USC. And the output was that, the washout is consistent with adrenal adenoma, but
Wait, I have a
lesions with
question.
an intrinsic, yes, go ahead,
You did wash out on this MRI or on a CT?
on CT, because
Oh, got it. Okay,
we've been following this very closely,
got
and
it.
it's been increasing over time. So when I read the CT subsequent to the MR as a follow-up.
And
So
that thing
then
you're just highlighting there about the greater than 43, that was exactly what I was talking about on the non-con.
yes,
Yep. Okay.
yes, right, and that's based on this paper here. And I wanted to review this paper because I didn't know that like dense lesions have a high pretest probability for malignancy, irrespective of washout. So this was a paper that was published in Radiology, 2005, so 8 years ago. And, it says non-calcified, non-hemorrhagic lesions with pre-contrast attenuation higher than 43. My lesion was 53 or 54. Should be considered suspicious for malignancy, irrespective of washout. I didn't know this, and I was reading through the paper to try to figure out what the PPV was, and it really there's a like everything you've got the sensitivity and specificity curve, and and so I wasn't really quite clear about how they came to that cutoff because I couldn't figure it out from this result section. But nevertheless, that was one of the take home points. And yeah, I didn't know that. And I don't I don't know what to do for this case. I mean, endocrine's been very like following it. Like I said, urine studies were negative. So they've just been following it, but the
I think
pre-con
it's still pretty
housing,
suspicious for a pheo,
right?
even if the urine is negative. And it doesn't mean that has to be resected or that it's a hormonally active pheo, but it's T2 bright. It's got washout. It was dense. Like, I think it's still like pheos in the differential. If they're concerned, they could do a dotatate and see if it lights up on that, which now people are using more than MIBG, I believe. And then one other thing, Nelly, go back to that Phil Chang website.
Yeah.
So I find this lower part of all the caveats here really helpful because he sort of summarizes the important caveats about this washout. And so one of them is this thing you're talking about, pre-contrast greater than 43 should be suspicious. Another is that the washout and like pheos have washout. So if you see a strong degree of enhancement in washout, like if it goes to, I think, greater than like 120 and then washes out, like it's really avidly enhancing and washing out, then I get concerned that even though it's meeting the washout criteria, it's actually a pheo. So I've seen several cases now where like we did the adrenal washout. We're like, oh, it's washout, it's adenoma, but like actually it was avidly enhancing and turned out to be a pheo.
Yeah, I feel like pheo, you can't really like. I mean, if it's not an adenoma, it could be a pheo. It's one of the things
Right, but
that I think
even some
about.
of these criteria, like it could meet the adenoma criteria for washout and
Yeah,
still be a pheo.
yeah,
So just like the washout, take it with a caveat.
yeah, agree.
So this is okay. So this is a outside study. So so all the prior care was done somewhere. So I don't know exactly what the decision making was. So don't quiz me on that. But this is a woman in her 70s, and this is her original CT. You can see that there's it's not an eyesight test, right? This is just big mass, which was reported as large, endometrial, a large mass centered on the endometrium, probably malignant.
Do you have the sagittal?
Yes. Let me stop sharing for a second because it's gonna de-identify for some reason. Give me a second. Can't see this. Okay, so it's de-identify, right? There you go.
Yes.
It's a
Oh
fair,
yeah, it looks endometrial.
right?
Like it's expanding the endometrium.
Right. So
And then
that's
maybe invading the anterior myometrium lower, like lower uterine segment. I don't know if it's arising from the lower uterine segment and expanding the endometrium, or it's a primary endometrial invading the myometrial.
so I
I
actually don't know how it was
need
reported.
MR.
Right. So I don't know how it was reported on the original study, but once it already got to us, it was reported as endometrial mass, get an MR. I don't know what happened, but 5 months later, patient gets a CT somewhere else again. And this is a scan. Right. So you can see that.
Wait, has it like grown into the fallopian tube now?
Well,
Or some
There's kind of obstructive process. Maybe there's like flu upstream. Okay. Oh, there's like
okay, so let me show you a
oh,
mark.
sarcoma. There's like a version, there's an endometrial sarcoma version. I think it's called ESS. I forget what the
Okay,
full
so
name
wait,
of
wait,
that.
wait, wait. Let's just figure out what's happening, okay? Before you jump to conclusions, I'm not saying you're
And
wrong.
where's the cervix? This I mean,
So
go ahead,
here's
yeah.
how about MR? MR is going to be more helpful.
Oh yeah. Oh my gosh, so much more helpful. Look at that. It's like it's coming in through the cervical into the vaginal fornices, no?
Right. So
Like it's
MR,
herniating into it. Yeah.
right. So in MR, it's much more obvious, right? So here's the fluid in the endometrial canal, which is much better than on CT. Let me just get the CT.
So in it herniated, is that what happened? There's like a
Yeah,
polyp and it herniated into the vaginal fornices?
great. So you can see
Oh,
here,
gotcha. So it's a
right?
giant polypoid
So you
mass.
can see a giant mass which was there uh, on the prior CT. It was centered in the endometrium. Now it's kind of prolapsing down. You can see that the endometrial cavity is markedly distended by probably blood. So then I think a few weeks after this, she gets an MR. And now you can see much more clearly that there's the hematometrus is markedly better, and you have this mass which is prolapsing. You can see it's heterogeneous, has a lot of cystic areas.
Does it restrict?
Um, I think again this is a
Because I mean, even though it looks kind of ugly, it doesn't look aggressive to
right.
me.
So our no, there's a diffusion. This is not our case. Oh, here we go. So there was a diffusion, which I will show you in momentarily.
I'm curious if like what people would have called this, like leaning towards like a polypoid, polyp or something versus a malignancy. I'm
So,
still concerned about a malignancy.
well, I'll tell you what I read it as.
Okay.
Okay, so I read it as this prolapsing polypoid mass, right? Large area of necrosis. It was on that, you can see it arising from the posterior and right with the stalk. So I gave the differential of prolapsing degenerated leiomyoma, atypical, endometrial polyp, or less likely like prolapsing adenomyoma. I'm not insane, right? But because you have all these cystic spaces, that's what I kind of like. I didn't think it was going to be that, but when you see so many cystic thingies, I kind of thought I have to think about it. So the path came back, and this is an interesting path. Really well, I'm showing this. The path came back as adenosarcoma, right? So then I'm like, oh crap, I really didn't think this through. But then when I read the path detail, it's actually pretty cool. This whole thing is a huge endometrial polyp. And there are like few microscopic areas of like sarcomatous changes. So it wasn't completely far off. This is just
Micro. So you're not going to see that by imaging? Is that what you're saying?
correct. So let me just get the exact path wording. Just give me a second. So tools there. Give me 1 second. I'll read it out to you. So the they give like the path. The original path. The big picture is adenosarcoma, right? Greatest dimension 8.3. But this is what the description is. The tumor was received detached from hysterectomy specimen, and the primary tumor location cannot be determined with certainty. The majority of tumor shows areas of resemble endometrial polyp and infarct-type necrosis. However, there are more cellular areas with focal leaf-like architecture that demonstrate moderate cytologic atypia and increased mitosis. These features are suggestive of high-grade component despite constituting a minority of overall tumor volume. So majority, even on path, majority of this thing looks like a partially necrotic endometrial polyp, but there are few areas of the sarcomatous change. So, but this is not something that we can, so obviously this had to come out, but it's pretty cool.
If I'm deducing what like Aarti has said in the past, where so is it like sarcoma kind of like an LMS, or is it like that endometrial
No,
sarcomatous
literally it says
variant?
adenosarcoma.
Oh,
so I don't know like if it can be classified into anything else, but the final path is adenosarcoma, even though the majority of, even on path, majority of this thing is infarcted polyp with few small areas of cellular atypia and mitosis, which made them say that this has a sarcoma component.
and this was on hysterectomy, or was it polypectomy?
Yeah, they took the whole thing out. Yeah, pretty cool, huh?
Great case.
Yeah. The reason I was like leaning a little bit more towards malignancy is I feel like the endometrial polyps that I've seen that prolapse like have a little bit better defined margins. Like this one seemed to have like spicules coming out of it, but it seems like a crazy case. And I found a paper. I'm just gonna try to summarize it quickly. Hold on 1 sec. Okay, so just I did find a paper about polyps overlapping with Mullerian adenosarcoma. And it's interesting because you hear the term adenosarcoma, so you think like, oh, it's going to be really aggressive. It has sarcoma in it, but it's a mixed Mullerian neoplasm with malignant stroma and benign epithelium. So, and apparently, there are some overlapping features with polyps, and overall have more of a benign kind of course.
Great.
So yeah, cool. Okay.
This is a patient of my colleagues, or a case, one of my colleagues' cases. And patient had this finding here in the adnexa. And I thought the pathology was really interesting. So the patient had a right cystic lesion seen on ultrasound, and this was a follow-up imaging study from the ultrasound, or yeah, as a follow-up of the ultrasound. So anyways, here's the right cystic lesion here. And here's the pre. Arterial. Here's your subtraction. And then we did dynamics.
Not very exciting, Nelly, except that on that T2, it had like that T2 dark rim, which is unusual for like just a simple cystic lesion.
Correct.
So
that's right.
One thing that I'm thinking about like is a cystadenofibroma.
Yes, that's exactly what this thing was. And I'm like, what is a cystadenofibroma? So we ORAD it too, or my colleague ORAD it too. The patient underwent surgery, and that's what the path was. So I looked it up because I wanted to learn more about it.
There's like a good paper. I remember it's called like Mimicker of Malignancy.
That one and this one. This one's pretty good too. So this is a really good. There's ovarian cyst adenofibroma. There's three types. This is type 3, which is almost like purely cystic. The most common is type 1. You get this multiloculated appearance, these T2 dark, they're very dark, yeah. And they do enhance these areas, they enhance. So that there's type 1 and then type 2. What's type 2 again? So this is that type 1 is the most common type. Like I said, ours is looking more cystic, simple cystic appearing, except that it has that dark T2 kind of rim around it. So it's not totally simple. So that's type 3. So this is, what is this? This is still type 1. These are just examples of the most common variant of cystadenofibroma. These multiloculated T2, and here's one, here's another one. And yeah, after a while, they all look the same. Like it has a very unique look to it.
Yes,
And
Nelly,
then this is the
I'm
type,
learned about this, like
go
that
ahead.
you scroll up, that's like a very to the prior one. This
This
is
one,
like
yeah.
memorize this look because
Yes.
this is really classic when you've got like really, really T2 dark areas and then bunch of cysts. Think about this cystadenofibroma because it is actually a benign thing.
And then type 2 is where you have a little bit more nodular, like it's not as conspicuous as this. It's you get more kind of plaque-like thickening, like there, right there. Then that's type 2, less common than type 1. Type 1 is the most common. And then type 3 is more purely cystic, like ours, I think probably would qualify as type 3. So anyways, this is a cystadenofibroma. This is not something that I typically think about, and something I kind of just recently learned because of this case. So this is, yeah, a good example of it.
Right. So this is again an outside study. So it doesn't have great technique. But patient comes in with this big the history is pelvic mass. So you can see that the patient has this big mass, right? And parts of it are cystic, there are septations, part of these kind of are intermediate signal intensity. And what caught my attention were these peripheral cystic thingies. And then here's the pre-contrast. You can see kind of in low areas of low signal intensity, areas of more intermediate signal intensity, and again, superiorly, almost like this daughter appearance.
I have like sometimes they describe this stained glass appearance where you have like locules with different levels of T1 hyperintensity.
Right.
And usually that's seen in like mucinous lesions.
Right. So that was kind of my thought that this is a probably mucinous lesion, but these peripheral things, daughter cyst, almost looking like daughter cysts, they concern me. So I knew that this was going to be a crazy call, and it was. And it's not as exciting as I was hoping it to be. But so I reported as probably neoplasm, but given that we have these peripheral daughters, peripheral cystic things, like at least exclude the possibility of ovarian hytadid. And when I looked, up ovarian hytadid, very rare, but they do happen and look very similar to this. So unfortunately, for patient, it wasn't, this is kind of like where the exciting case would benefit the patient. So unfortunately, this was borderline mucinous neoplasm, not the fun hydatid cyst. Another interesting part is that there is a Brenner tumor somewhere in this big thing. So it's a left adnexal, left ovarian, borderline mucinous tumor with background of Brenner tumor, which knowing where it is, that it's there on pathology, I don't know where it is on imaging. Another interesting thing here is that ovary, the right ovary is described to have a Brenner tumor as well. And I wasn't sure, maybe this is it, but really this is not kind of callable prospectively.
Can you show the T2?
Uh, sure.
Those Brenners are supposed to be in like the sort of T2 dark solid.
Yeah, but like, right, like this looks just like a normal
Yeah.
parenchyma. There's not, like, I tried, I went back, and there's no DWI here, by the way. This is an outside study. Another interesting part here is that they actually took out the appendix, and the appendix had borderline mucinous neoplasm as well. But when I went back, I mean, is this it? I don't know. I don't think we can see it at all. I try to find it and see if we can kind of see it. But so I don't know, like, if there's association between the mucinous of
Is
ovary.
that T2 dark part, like the one you're pointing at on the left screen? Is that what you're thinking is the Brenner part?
That's what we thought, there was solid enhancing component. So there was no subtraction here, so that was a little concerning. The original the error was saved by the fellow who thought this was part of normal ovary, but I didn't think so. I thought this was the solid component. I don't think we can see like a normal ovary here. But you see, like, why I thought that maybe this is look at these all peripheral, but again, not as exciting as it could have been. So anyway, so I think this T2 dark part corresponds to something that we can confirm to be a solid component.
There is a relationship between appendix and ovarian mucinous
Yeah.
tumor. And
I was gonna say, we've talked about this before here.
I think so. I just pulled up a Google case because a paper from Google. And often when they resect the ovarian mass, they almost always do an appendectomy. It's like part of the surgical
It used to
procedure.
be. It used to be. I've
Oh,
actually
it's
noticed that
old.
they stopped doing that. It used to be standard where they would take out the appendix for debulking. But
Yeah.
I've noticed that it's not always the case. And I don't know if these are new guidelines, but I've noticed recently they stopped doing the routine appendectomy. So I don't know.
Interesting, but Nelly, that paper you just showed,
Yeah.
said that even if they find two tumors, they're usually two independent tumors. They're not necessarily related to each other.
Yeah, I don't know if it's a chicken or the egg, but there is an association, even though they're independent, like, lesions. This is a patient with a prostate lesion. So here it is. The question is not really about the presence of it. It's more what you would say in terms of the capsule. Like, how would you describe EPE? So the tumor is right here. It's pretty small. On the satchel is right here. Go ahead.
Is it bordering the capsule by more than 1.5 centimeters?
No, it's less than 1.5.
Okay, because I know that has is that, well, tell me
Yes.
if this is true.
Yes,
Okay.
it does. Yeah, tumor contact length. Right.
Okay, but otherwise it seems kind of like a clean border, although it's weird because the rectum is like pushing up against it, so you kind of have that clean border, but I don't see it definitely invading that T2 dark muscularis of the rectum.
So you're saying that there's no EPE?
Yeah, but it's touching this muscularis of the rectum there, right?
So yeah, the rectum is here. This is serosa of the rectum is maybe that T2 dark line.
Yeah.
The prostate, I'll tell you that the way they acquired it, this was an outside interpretation. It was like directly axial. It wasn't, I don't know if we're supposed to do it, but it's not orthogonal to the longitudinal axis of the prostate, just like we do uterus and things like that.
Okay, I'm changing my mind on that right there posteriorly, like there's like a little tongue going backwards. Like, yeah.
This thing, yes. So so there's the peripheral gland, and then maybe the peripheral gland ends here, maybe. And then there's that tongue of T2 signal. So what would you say in your report? So, and then this is a diffusion right here. Like I said, this was an outside study, so it was just a little bit, there's a little gas and stuff like that, so it's not ideal, but so you would say there's
Okay, concerning.
EPE, no EPE, no concerning. Okay. Yeah, and that was how it was read. Like there's EPE and probable neurovascular invasion. And patient underwent a radical prostatectomy, and the surgeon took very wide margin based on the MRI interpretation, and there was no EPE, no EPE at all. I think this is an area of opportunity for us in radiology, is really trying to classify, what is EP and what is not EP. There's a great paper from Barris's group that was published, and they proposed this grading system that I started using because my colleague Akira uses it. And I asked our urologists, and they find it to be very, very helpful. Rather than just kind of describing it and blah, 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 it's more of a scale, right? So that it's just like any of the skills that we use, the higher the score, the more worrisome it is. And it goes from 1, 2, and 3. So, and that's the 1.5 centimeter tumor contact length that Aarti was alluding to earlier. So, grade 1 is the curvilinear contact length. So it's like 1.5. Or there's bulging or irregularity. So it's an or statement. So if you have this or that, then it's grade 1. If you have both tumor contact length of greater than 1.5 and irregularity or capsular bulging, then it becomes a grade 2. But look at that. Even when you have that, like the sensitivity is like only 40%. Okay, so it's not that like high. Grade 3 is where you see kind of obvious extra-prostatic extension, right? There's tumor here invading the neurovascular model. Even with this, since the sensitivity is 66%, right? I mean, you think this would be very high, but it's not, right? It's only 66. So I do use this, and I started using this, and I because our urologists find it helpful. And for me here, right, it would be just grade 1. Grade
So are
1.
you telling us that we should like undercall these, or my impression was like it's better to. Okay, so I have a question. How is this going to change clinical management? Like if there's EPE, will that actually change if they're like how they do the surgery or what they're going to do? Or
So they took a wide margin on the left, and so the neurovascular bundles are gone. So the patient's risk of impotence post-op is very high.
got it. Okay.
I mean, it has functional outcomes, implications for functional outcomes.
Okay. So
Post-op.
instead of overcalling it, we might, based on those positive predictive values you just said, we might
Sensitivity.
want to undercall it.
I undercall because the data suggests that MR is not actually as good as we think we want it to be for EP.
And what
Evaluation.
explains that, like that appearance on that last one where you only have the 66?
This is shocking, right? Look, I mean,
does it induce desmoplastic reaction the way that like
I don't know why.
Okay.
Why the sensitivity is lower than what we expect it to be. Maybe desmoplastic reaction. I don't know, but the sensitivity is not that good. Even with frank imaging findings of EPE. So anyways, if I were reading this, like I said, I would call it this grade 1. And I heavily rely on diffusion for EPE evaluation. So here to me, it looks confined. So even though there's that tongue that Aarti was mentioning, like on diffusion, it looks confined. I mean, granted that diffusion is not optimal, but it's okay. But to me, it looks confined on diffusion, so I would undercall this. It's a tough case though, because if you ask 3 radiologists, all 3 will have different opinions. So there's no consensus per se in this area. And it's just opportunities for us to learn and be better. So
yes, thank you.
We have this
okay, so here is a patient with peritoneal disease. You can see that there is all this induration and nodularity of the omentum and ascites. And in this case, it was from ovarian cancer. We don't see the primary ovarian malignancy is gone. There were some retroperitoneal lymph nodes as well, and they underwent 3 months of chemotherapy. And now you can see the peritoneal disease is much better. A lot of the ascites is gone. A lot of the omental nodularity is gone. Even the retroperitoneal lymph nodes are better. So really nice 3-month response to chemotherapy. They had carbotaxol. But does anyone see any additional new findings?
Can you do a side by side? Because there's a lot on the pre-treatment CT.
Okay, hold on, let me try. It's really sad. Oh, here. Hold on, please stop recording for a second. Okay, so this was the original, the OG. Stop in this region. And then this is the new exam. I'll say that there's some findings on the new.
Oh, the pseudoaneurysm. Oh, go ahead.
Yeah, good. And also, like, what do you think about all this?
Can you scroll to that area on the right, on the old one? Oh, it's all bleeding.
Yes, exactly.
Wait, the
So all the
pseudoaneurysm wasn't
peritoneal,
there. Wait,
yes.
or we just couldn't see it because the timing was off.
No, so the peritoneal disease in ascites is basically significantly decreased.
Yeah, there's
But
like a
now we have
GDA.
like a retroperitoneal thing, and we've got a really bright little dot here. So this was retroperitoneal hematoma and a pseudoaneurysm. And just to be absolutely sure, they ended up with a CTA. And
Who was it from? I mean, I don't, maybe we don't know.
it's a branch of the GDA. So there it is.
What caused it?
Oh, yes. So that's part of the discussion. So, well, first of all, one point is that we're not going to call this metastatic disease because, first of all the rest of it has gotten better, and ovarian, cancer doesn't usually go to the retroperitoneum, so that would be weird. And then on top of that, you've got this beautiful little pseudoaneurysm here, right? That we can even trace the input and output coming from the pancreatico-duodenal arcade and branches of the GDA. So we don't know what caused it. So this brought up the discussion that sometimes pancreatitis, like the most common cause for a GDA pseudoaneurysm would be pancreatitis. And sometimes that can be caused by treatment for cancer, specifically immunotherapies. So we looked up different immunotherapies that are associated with pancreatitis. This patient was not on any of those. They were on carbotaxol, and there are some case reports of pancreatitis induced by that chemotherapy. So it's not like a frequent association. We don't know if that's exactly what caused it, but that's the theory right now, is that they had like this robust response to their chemotherapy, great response, but maybe it induced a pancreatitis that caused the pseudoaneurysm and this retroperitoneal hemorrhage. And then they embolized the pseudoaneurysm. So just a pretty example of one. Yeah, but in general, GDA pseudoaneurysms are usually from pancreatitis and sometimes from trauma. Victoria has to go.
This is a patient with like a pretty big prostate tumor here on the left base. So the question here is about SVI. So this, I would definitely give this grade 3 in terms of EP, right? We see tumor, there's your ELO grade right here, tumor outside the prostate margin, right there going up. And the SVs are here. Here's one on the right and then the left. So the SVs are there. So what would you say about the SVs? Is there seminal vesicle invasion or no seminal vesicle invasion? So here's your sagittal, and here's the diffusion, which demonstrates restriction at the area of EPE here, this. So your SVs are here on the left. Here's your tumor, and then here's your base, prostate base.
I would have said suspicious, but
Agree. And I would say the same.
because there's
SVI.
all that like speculated stuff all around
100%.
SVs
Yep.
and all that gray stuff.
Yep. I mean, for me, this is like SVI, right? I mean, and there was no SVI. There was EP. The patient had a radical prostatectomy. Again, it was like they just took as wide of a margin as they can because the tumor was so big and it was just so scary looking. And on radical prostatectomy, there was no SVI. This is all tumor though. This is all tumor, but there's no SVI.
Do the seminal vesicles have a capsule?
I mean, it's a sac, right? So I mean, I bet it probably has all the layers. I don't. It's not like a prostate, like where there's just that fibrous, outline. Like it's. I don't know
Okay,
actually.
but
I
in
don't
this
think
case, I
so,
don't
but I
think
don't
this would
know.
have changed that much of management.
Agree. Yeah. No, SVI makes a T3B, but it's not a big deal, because functionally or kind of for what it's worth, it's going to act like an SVI. Like the prognosis is worse if they have SVI compared to if they don't. Like risk of biochemical recurrence is higher because the stage is higher. But here the tumor is, like pretty significant. So surgically it didn't really change the outcome. And the study is interesting just because of the discordance between, pathology versus what we called on MR. But clinically, I don't think it makes a meaningful difference. The urologist was just surprised by the path, based on what we had reported on MR. And I think in some institutions, they instruct patients to not ejaculate for a few days prior to their prostate MR appointment so that they can see the SVs better, keep it distended. In this case, the SVs were decompressed. So I think that maybe distension views can improve the conspicuity compared to, if it's decompressed like this.
Cool. Yes, in my training, we had them abstain to distend the seminal vesicles, but here we do not. Okay, this is a patient, very complex history. You can see that there's super severe anosarca, and there are some abdominal findings that are very hard to tell given how bad the anosarca is. But my question is, do you guys know what this is? I had not seen one of these until last week when my fellow showed this at our interesting case conference. This device here. Hello? Can you guys hear me?
Yes. We can see and we can hear you. I don't know what that device is.
Okay. So I'll give you another clue. This was, they had an enterocutaneous fistula. And this is what is called an enterocutaneous fistula plug. So it is something that IR colleagues can put through the fistula's tract into the abdomen, and then they put like a plug here, hoping that it basically seals off like the small bowel hole that's causing the fistula. And I'll show you what this looks like on, can you guys see this? So it looks like this. And one part of the plug is on the skin, and the other part is they thread it through the fistula and then deploy it in the abdomen. And basically it's sort of blindly deployed. So you're hoping that it's, there's a direct line between the hole in the small bowel, the fistula, and the skin. So yeah, that's how it works. And then eventually this dissolves and they can just pull this guy out. And hopefully no more, contents are coming out through the skin. In this particular case, it did not work because there was not a direct line to just a small hole in the small bowel. It was actually like it was leaking out into a fluid collection that then went out into the skin. They actually did. There was a pigtail catheter in this collection, so they injected contrast into it like a little while later, and you can see that the contrast is frankly communicating with small bowel loops. So that in this case, this enterocutaneous fistula plug was communicating with a fluid collection, not just like a singular hole in the small bowel. Therefore, it did not work. But anyway, just so you know that this device exists.
Cool. One of my colleagues, Rami Oklu, he's one of our interventionalists, and he created a material. Actually, it was FDA approved and now available on the market for embolization. Like it's an absorbable material, and now they're testing that on EC fistulas to plug that stuff up. But it's a liquid version. Anyways, very cool stuff that's coming out in this area. Okay, so this is a patient with history of right lower quadrant abdominal pain. So here's our cecum here, and the TI is right there. And then just anteriorly is the appendix, abnormal looking. What are your thoughts?
To me, it looks like a ruptured distal appendix.
Good. Good. Yes. So that's basically what this was called. And the patient went for an appendectomy, and this came back as mucinous neoplasm of appendix. And so then the patient went back for a right hemicolectomy. So this was a case of a perforated appendiceal cancer with mucinous features.
Can you scroll through again?
Yes.
Okay, so in retrospect, would you have called it like, it doesn't look as distended as like a mucocele usually looks, although I agree that the wall looks kind of thick.
Thick and irregular, and maybe there's a couple of nodes there. It doesn't have the same inflammatory process. I think it would be a very amazing call if someone called that prospectively. But I think it's important for us to see this, right? So that things that can fool us, right? Because appendix is obviously abnormal, but
but that thickening of the appendix going along is a little weird. What do other people think?
Soft tissue-y.
And now, next time you see this, are you going to bring up malignancy?
And the base is distended with soft tissue stuff, like rather than just, kind of
that could easily be ruptured, like just phlegmon rupture,
That's fair.
Kedar, I'm going to put you on the spot. What do you think?
No, I agree, but what was the age of the patient, Nelly?
The age of the patient was in their 60s.
I mean, I think
at that point, late 50s.
You kind of have to consider malignancy also, I feel.
Tarun says difficult to call this as tumor. Melina, what do you think?
Yeah, it's so hard to call it as tumor.
Yeah.
We've seen so many cases now of, diverticulitis, which had tumor hidden there. So I think after a certain age, we should at least think about it and do a follow-up and see what happens.
Yeah. That came up recently, like people are asking about diverticulitis versus tumor. Before they used to recommend a colonoscopy for everybody who had diverticulitis. Now they've seen that like most of those patients don't benefit from the colonoscopy. They're usually just diverticulitis, but some of the more alarming, worrisome signs are like thicker enhancing wall of the colon, shorter segment, and then any nodes. So what Nelly just showed, there were some like kind of like little nodes or nodules around. So I guess that is kind of a little bit more concerning. Nelly, I have a question though. Those nodes around that one, or like the little nodules, that wouldn't be like a typical low-grade appendiceal mucinous neoplasm. That would be more like a mucinous adenocarcinoma. So is that what this was? What was
The pathology it said appendiceal cancer. It's appendiceal cancer with mucinous features.
Okay, so that's more of like the actually aggressive end of the spectrum, like mucinous adenocarcinoma.
I suspect
rather than a lemon, like
yes,
like
it's not a lemon, not a lemon. Yeah.
Okay, that makes sense. And then now I'm looking, yeah, there's like lots of little nodes here. Okay. Note for the future.
So there's a 31-year-old patient who had radiation therapy for some pelvic cancer. And while seeing the patient, this is what we saw. This is it on T2. This is SAG T2. No? And then this is how it is on T1. And then on fat sat, they completely sat out, whatever these things are. And I mean, we really didn't know what to call it. I called it some lipoma of some complex lipoma or lipoma of some of the, what did I call it? Labial lipoma, but just for want of.
Yeah, why are you calling lipoma when like it is dark on the T2?
Yeah, but look at how it is on T1.
But that means that it's something that is, I can't say that then that means it's a lipoma though. That means
No,
that
I agree, but I mean completely sats out on fat sat, right? Completely
or it doesn't enhance.
Well, I agree, but even if it, whether it enhances or not, I mean, it's.
Wait, do you have fat sat T2s?
Do I have fat sat T2? Probably not. No, we don't do fat sat T2s for female pelvis, so no, I don't.
Question,
I mean,
another question: has the patient had any history of injections or?
No.
Okay.
No history of injection. That was, we had thought about that, but there was
no.
no.
Yeah, Tarun says any augmentation procedure or iatrogenic.
No, we didn't get any such history.
Okay, then what about like weird undescended testes? Like, is there?
Okay, so there is no sex change therapy or treatment also. We thought of all of those things.
No. Okay, but not even treatment. Like what? Like, has they done karyotype?
Congenital.
Like, because there could be like apparently like 10% of people have some kind of ambiguous gender.
It should enhance though, unless you think it's atrophic. Like it's not enhancing.
Yeah. But it could be atrophic. Yeah.
Yeah, I guess we really did not think about that. Years. I mean, we thought about it, but we didn't get any histories about it.
Is the location good for a Bartlett? Or maybe it's too anterior, huh?
It's too. Look at this. This is all fat.
Yeah.
Here's a CT.
So, I mean, just to give you an example, like we had a patient who had like a micro penis and then a rudimentary uterus that was herniating into an inguinal canal. But
wow,
anyway, when I looked it up at that time, I was like, how can they have like both a penis and like part of a uterus and all the stuff? And there are all these different syndromes where you can get development of these different things. But I agree with you now, Kedar, like looking at that CT, like it is fat.
And
it looks benign looking, like
this signal, but that's what it was. And I mean, it was there on previous studies, and I mean, somehow none of us had looked at it. And this last study, this just kind of stood out as, you know, balloons.
So what's going on with the uterus? Like
there's a cancer.
Oh, okay.
She has a known tumor. That's different. It was just, this was incidentally seen, and like we had no idea what to call it.
Gotcha.
Given that gray appearance on the T2, I might have been like, are those nodes or like some kind of mets? But then like on the CT, I'm really convinced that they are fat. So maybe just kind of weird fat necrosis. Okay, so this patient got referred because they had an EUS, they had some abdominal pain. They ended up with an EGD and an EUS. And on EUS, they found what they thought was a GIST tumor arising from the stomach. They did ultrasound through the stomach wall and saw a large mass, and it looked like it was arising from the fourth layer of the bowel, which is like usually the muscularis layer, and called it a GIST and did a biopsy, and the biopsy came back sort of non-diagnostic. So anyway, here is the lesion abutting the stomach here.
Is that fat in it?
It looks
Or
like a hemangioma if you put that in the liver.
do you have the fat set images
Here's
also?
the fat set.
Oh, okay. Just kidding. It's not fat.
So it's not fat.
Yeah.
And here's the pre-contrast, post-contrast.
Oh, yeah. Kadar's hemangioma is starting to look more promising.
Yeah.
There it is.
And then there's the delayed. Okay, so this was just a cute fake out. In that this was a hemangioma. The T2 is very classic. Kadar got it immediately. Very well, very bright. And then this, more central fibrotic scar actually is even more bright, T2 bright. That's very classic for a bigger and bigger giant hemangioma. And even though it looks like it comes from the stomach and it looked like that on EOS, it's actually just arising from this left tip of the liver. And that's the other teaching point I wanted to make, which I've missed lesions hanging off the left tip of the liver. You can have like big masses even hanging off here. And so just make sure you follow all the way to the end. And this was just a hemangioma hanging off the end there.
Sorry, did you say that T2 bright area is a scar?
Yes.
Like, aren't scars dark on T2?
They usually are, but in hemangiomas, they're brighter. And I don't know if scar is the proper term. Maybe let me Google this, but
It looks cystic. Like,
this is Nelly. This is the classic appearance of the center.
I believe you. I believe you. I
Yeah,
believe you. I'm just
no, but,
wondering,
but
trying to
I'm
make sense of the
thinking-
signal, the
I
T2
know.
signal. Like,
let me see what the proper name is for it. But the other important thing about this is that it will never fill in. So even if you get like a super delayed, the rest of this will fill in, but this guy won't fill in. And that's why I call it a scar, because it's not like communicating with the rest of the hemangioma. But let me get the proper name for it for you. At least what I'm finding in radiographics and radiopedia says like they can have central necrosis or liquefaction with maybe the result of ischemia or hemorrhage.
okay.
Yeah.
That makes
I don't know exactly if scar is the proper term, but it is generally very T2 bright and does not end up progressively enhancing. Yeah.
Awesome.
So it's just a cute little mimic, and even a US can be hard to tell.